Welcome to Lecture 13. In this lecture, we will review the most common complications of the cesarean section and its post-operative care. When discussing complications of a C-section or delivery, it is important to be able to classify the complication. Some important and useful classifications include language such as common or uncommon, major or minor complications, immediate or delayed, or intraoperative versus post-operative complications. Another way of classifying complications is using the NICE categorization system. This system relates a term to a number, as listed here. For example, very common means there is a risk of this complication of about 1 to 10 in 10 people, whereas very rare is a complication that occurs in 1 to 10 out of 100,000 people. When discussing risks with patients, using both words and numbers may be helpful. For example, the risk of uterine rupture at the time of C-section is uncommon, about 0.5% or 1 in 200. The most common complications of C-sections are infection and hemorrhage. Other complications include things like anesthetic complications, subsequent placenta previa, breastfeeding concerns, urinary incontinence, surgical and traumatic complications, subsequent uterine rupture, hysterectomy, subsequent infertility, anorectal function, sexual function, pelvic organ prolapse, subsequent stillbirth, and maternal mortality. We will be reviewing the most common complications of C-section as well as some of the most serious complications. There are many factors that contribute to post-operative infections as listed. One of the most important factors is maternal health and BMI. Elevated BMI increases the risk of post-operative infection, and underlying maternal conditions, such as diabetes, can also increase the risk of infection. Another factor that contributes to infection during the labor process is ascending infection. This is more likely to occur after the water is broken and the protective layer of the amniotic membranes is interrupted. This can cause an infection during labor called chorioamnionitis when the placenta and membranes are still in the uterus, or a postpartum infection called endometritis, which is an infection in the lining of the uterus. Similarly to ascending infection in the uterus, bacteria can ascend the urethra and cause urinary tract infections, which are known as UTIs. We would like you to think about what factors may contribute to infection with abdominal incisions at C-section as we progress through the next few slides. Important infective complication to be aware of are intra-abdominal abscesses. These can form after surgery spontaneously or at the site of a hematoma or seroma. This is why it is important to ensure excellent hemostasis during a C-section to prevent large hematomas from forming and reduce the risk for infection postoperatively. Intra-abdominal abscesses can be difficult to diagnose without ultrasound or CT imaging, and patients can become very sick very quickly. Thus, you should always think about this possibility if a patient presents after C-section with infective symptoms. Hemorrhage during labor and delivery is the most common cause of maternal mortality worldwide. It is very important to be aware of this risk and how to reduce the risk of heavy bleeding, especially at the time of C-section. The pregnant uterus is extremely vascular with large amounts of blood moving through the vessels every minute. Once the uterus has been incised to deliver the baby, heavy bleeding can start. It is important to ensure the uterine incision is closed as soon as possible after delivering the baby and placenta. The same causes of postpartum hemorrhage that occur at a vaginal delivery can occur with C-section. The 4 T's, including tone, tissue, tears, and thrombin, must be considered. You should ensure there is no placental tissue left in the uterus prior to closing the incision. The tone of the uterus should be continuously monitored and uterotonic medications administered once the placenta is delivered. And uterine extensions must be repaired as well as the hysterotomy site, and you should always consider coagulopathies if heavy bleeding is occurring. Management principles of an intraoperative or postpartum hemorrhage at the time of C-section follow the same principles as the time of vaginal delivery, as discussed in Lecture 8. Bimanual massage can be performed, the bladder should be emptied, and you should ensure there are 2 I-5 access sites placed with a wide bore needle. Once the placenta is delivered, uterotonics should be administered, such as oxytocin or carbetocin. Carbetocin is more commonly used at the time of C-section. If there is still ongoing bleeding, other uterotonics can be administered, including ergometrin, carboprost and misoprostol. Please pause the video to note the doses for each medication. Some other less common complications associated with C-section can be extremely dangerous and have serious effects. Some of these complications are related to why a C-section is being performed and include placenta abruption and uterine rupture. The risk of uterine rupture with a history of one prior C-section is 0.5%. Placental abruption is when the placenta detaches from the endometrium prematurely and often presents with painless vaginal bleeding and abnormal fetal heart rate. Whereas uterine rupture usually presents with abdominal pain and abnormal fetal heart rate. Both of these presentations are an indication for C-section and can lead to significant blood loss and patient instability. Infection can worsen and become a systemic infection that can turn into sepsis and septic shock. The main signs of septic shock include tachycardia, hypotension, and fever. Once septic shock is recognized, immediate antibiotic treatment is required as well as supportive management to stabilize the patient and treat the underlying cause. Blood clots are a common cause of maternal morbidity in North America, but well behind bleeding and infection in most of the world. Diagnosis may often be made clinically, and should prompt treatment with anticoagulation with medications such as heparin or other anticoagulants. Clinical signs of a blood clot such as a D5T, or deep vein thrombosis, is swelling, erythema and tenderness in one leg more than the other. Signs of a PE, or pulmonary embolism, include chest pain and shortness of breath. The risk of PE after C-section is 1 in 2,000. Amniotic fluid embolus is a very rare but serious complication that can occur at C-section. It is when amniotic fluid is pushed into the maternal vascular system, likely due to uterine contractions. This fluid embolus can then travel to the heart and lungs, leading to respiratory distress and possible cardiac arrest. In the full-blown form, an amniotic fluid embolus has a case fatality rate reaching 60%. In summary, you should always be aware of the types of complications that can occur and how to treat them. You do not want to intervene unnecessarily as this can cause harm, but proactively preparing for and appropriately managing C-section care will reduce complications. Using excellent surgical technique will help lower the risk of complications such as infection and hemorrhage. Over the next few slides we will discuss post-operative care principles. The immediate post-operative period is when most of the serious and acute complications occur. Immediately post-operatively, you should ensure clear orders are made to monitor the patient and that all care team members are aware of the patient's plan. You must monitor vitals and set up routine post-op orders such as diet and activity. Patients should be encouraged to have a regular diet and walk out of bed within 24 hours. If they have I5 fluids running after the surgery, clear instructions should be given for how long to let these fluids run and when to stop them. If there are any complications, specific investigations should be made clear to the post-operative care team, such as repeat lab work or blood cultures to assess for systemic infection. If there was a heavy bleed, the patient's urine output should be monitored. Lastly, any specific medications required should be clearly stated, including routine post-operative pain medications. Specific routine post-C-section care steps are listed here. Antibiotics should be used prophylactically prior to starting the procedure and as available if signs of infection. Sufficient pain medication should be used so that the patient is as comfortable as possible post-op. I5 fluids should be continued until the patient is drinking well. They should ambulate as soon as possible, and they should be eating and drinking as soon as possible on the same day of the surgery. There is no need to wait until post-op day 1 to start eating a normal diet. Diet should be advances slowly immediately post-operatively from clear fluids to normal solid foods. Lastly, it is always important to remember that post-operative care is patient-centered care. When caring for a patient, you must think about the whole patient and what is best for her and her baby from the time she arrives to your care until she is discharged home.